Today I will talk about metastatic tumors. Metastatic tumors. Metastatic tumors greatly outnumber primary bone cancers. The pathways of tumor spread to bone include direct extension, lymphatic or hematogenous dissemination, and intraspinal seeding via the Batson plexus of vein. Any cancer can spread to bone, but in adults more than 75% of skeletal metastases originate from cancers of the prostate, breast, kidney, and lung. In children, metastases to bone originate from neuroblastoma, Wilms tumor, and rhabdomyosarcoma. Skeletal metastases are typically multifocal and involve the axial skeleton, especially the vertebral column. The radiographic appearance of metastases may be purely lytic bone destroying, purely blastic bone forming, or mixed. Bidirectional interactions between metastatic cancer cells and native bone cells account for the changes that manifest in the bone matrix. Tumor cells secrete substances such as prostaglandins, cytokines, and PTH-like peptide that upregulate RANKL on osteoblasts and stromal cells, thereby stimulating osteoclast activity. The presence of bone metastasis carries a poor prognosis. Therapeutic options include systemic chemotherapy, radiation, and bisphosphonates. Surgery may be necessary to stabilize pathologic fractures. Summary: major categories of primary bone tumors include bone-forming, osteoblastoma and osteoid. Osteoma consist of benign osteoblasts that synthesize osteoid. Osteosarcoma is an aggressive tumor of malignant osteoblasts, predominantly occurring in adolescents. Cartilage-forming, osteochondroma is an exostosis with a cartilage cap. Sporadic and syndromic forms arise from mutations in the EXT genes. Chondromas are benign tumors producing hyaline cartilage, usually arising in the digits. Chondrosarcomas are malignant tumors of chondroid cells that involve the axial skeleton in adults. Ewing sarcomas are aggressive, malignant, small round cell. Fibrous dysplasia is an example of a disorder caused by gain-of-function mutations that occur during development.